It is my immense pleasure to present this case titled Lost in Transit, The Unexpected Passenger. My guide is Dr. Ramdas sir, Professor and Chief of Unit S3, Institute of General Surgery, MMC and RGGH. So, in this presentation, we will cover history and examination, differential diagnosis, how the patient was diagnosed, and how she was managed, the significance of this case, and some discussion about this topic. A 28-year-old female presented with chief complaints of inguinal pain on the left side for the past 3 days. She had inguinal swellings on both sides, which increased in size on coughing and decreased on laying down. It was easily reducible. And she also reported coital difficulties on eliciting further history. And she has also not achieved menarche yet. So we proceeded to examination of the swelling. General and systemic examinations were normal and unremarkable. Vitals were normal. Local examination of the swellings revealed the swelling was 4 cross 3 centimeter in size. It was present in the mid-inguinal point, extended from the mid-inguinal point. Skin over swelling was normal. Swelling was mobile, reducible. And there was tenderness on both sides in the inguinal region over the swelling. Cough impulse was present. And on deepening occlusion tests, it was concluded that this is a indirect inguinal hernia because the deepening occlusion tests was positive. And the secondary sexual characters were present in this female. So with this history and examination, we propose certain differential diagnosis. This person, the female, could be a patient of Turner syndrome with gonadal distance and presenting with inguinal hernias. She also could have complete androgen insensitivity syndrome presenting with inguinal hernias, transverse vaginal septum, or imperforate hymen, or congenital adrenal hyperplasia presenting with inguinal hernias. So we performed certain investigations to rule out these differential diagnoses one by one. CBC, LFT, urine tests, electrolytes, infertility profile, ultrasound abdomen, pelvis, CT abdomen, everything were taken. In the next slides, we will see the complete blood count revealed complete blood count and other urine analysis electrolytes revealed only elevated random blood sugar, which through which we found out that the patient is a newly diagnosed diabetes mellitus type 2 patient. And LFT and lipid profile were normal. No abnormalities were found. Infertility profile was taken because the patient was having coital difficulties and has not yet achieved menarche till 28 years. So infertility profile was also normal. AMH is 1.06, which is in the borderline low, but still the total testosterone level was in the female range. This eliminated the possibility of having an androgen insensitivity syndrome, where the testosterone levels could be normal or mildly elevated. It's usually elevated, sometimes can be normal. And FSH, LH, estrogen, progesterone, everything were not in the normal female range. And dehydroepiandrosterone levels were in the female range, and it is actually normal. So this eliminated the possibility of having a congenital adrenal hyperplasia. So we performed certain investigations. The USG abdomen pelvis revealed a right solitary kidney, and the uterus and cervix were absent or rudimentary. The CT abdomen revealed a right solitary kidney and absent uterus. In the CT abdomen, we were able to appreciate the canal of Nuck, which was patent on both sides. And we also found out that the inguinal hernia, indirect inguinal hernia, had ovary and omentum as the contents. So this is a CT image showing the swelling in the right inguinal region, and this is in the left inguinal region. So the gonads are normal. The ovary is normal, but it is in the abnormal position, abnormal place. It is in the inguinal hernial sac. So gonadal dysgenesis um, is eliminated because there is no streak gonads, and complete androgen insensitivity syndrome is also eliminated because the androgen levels are in normal female pattern. Transverse vaginal septum and imperfect hymen. In the further slides, we will see it was um, eliminated. The differential diagnosis were ruled out by performing uh, MRI of the pelvis, which revealed there is no transverse vaginal septum. There is vaginal agenesis. The upper two-thirds of vagina has not yet formed. And congenital adrenal hyperplasia is also ruled out because the DHEAS values are normal. So we have ruled out all these differential diagnosis. So without a diagnosis, we now thought about what to do next. So pervaginal examination also pervaginal examination is a general easy examination thing we can use to rule out high imperfect hymen and transverse vaginal septum. Transverse vaginal septum during pervaginal examination will appear like a reddish um, membrane or not a thicker membrane, which is hard to palpate and present superiorly, usually superiorly. An imperfect hymen usually is filled with blood during each menstrual cycle and appears as a bluish bulging membrane. So we also performed the karyotyping, which revealed a normal female karyotype. And there is presence of ovary in the inguinal canal, which we already saw in the um, CT and MRI of pelvis. Breast development was in normal stage. We already in examination noted that the secondary sexual characters were developed. Female pattern pubic hair is also present. So based on this, we are able to find that uterus is rudimentary or absent, and upper two-thirds of vagina is not formed properly. So Mullerian structures are not formed. So this is a Mullerian agenesis. And the patient having normal secondary sexual characters, and she also has normal height that is required for a female at this appropriate age. So in a female with normal height with secondary sexual characters with primary amenorrhea, we have to suspect Mullerian agenesis and mainly Mayer-Rokitansky-Küster-Hauser syndrome. So we performed further investigations to find out what type of MRKH this case is. CT spine revealed no abnormality. ENT evaluation was also performed, which was normal, but there was only right solitary kidney, which means the left kidney is absent in this patient. So there's one extra gonadal manifestation, that is absence of left kidney. So this says that this patient has type 2 or atypical Mayer-Rokitansky-Küster-Hauser syndrome, where the type 1 Mayer-Rokitansky-Küster-Hauser syndrome has extra genital manifestations, does not have extra genital manifestations. Only Mullerian aplasia will be present. In the type 2, which is the atypical MRKH, extragonadal manifestations like clipal fail abnormality in the spine, ENT conductive hearing loss, or kidney and renal abnormalities like absence of kidney are usually present in the atypical type. So finally, we diagnosed this patient having atypical Mayer-Rokitansky-Küster-Hauser syndrome presenting with bilateral inguinal indirect hernias. So to correct the inguinal hernia, we planned to perform bilateral inguinal transabdominal preperitoneal mesh repair for this patient. Because the patient was diabetic, we also got the diabetologist opinion along with the anesthesiologist opinion, and the patient was prepared for surgery. During the surgery, we performed a transabdominal preperitoneal mesh repair. Left ovary and the rudimentary uterus was present in the left inguinal canal, and the right ovary was present in the right inguinal canal, which was repositioned and sutured to the lateral abdominal wall. And after this, we performed the mesh repair for the inguinal hernia, and this is an image showing the left ovary, the rudimentary uterus. This is the right ovary with the right ovary, and The hernia is not yet closed. Now it's closed in this image. The hernial defects are closed and the ovary is sutured to the abdominal wall. This is a post-op picture. Patient recovered very well. She was counseled and managed by a team of plastic surgeons for vaginoplasty. But the patient cannot have children. She can have children of her own by IVF and surrogacy. And for future sexual prospects, she was advised for vaginoplasty. So the significance of this case is ovarian herniation is usually rare. Like 2 to 3% of the inguinal hernias have ovaries content. But it is extremely rare when it is associated with MRKH syndrome. Only very few cases are reported in this, about related to this. Very few cases. So the discussion part. As I already said, MRKH, which is Mullerian agenesis, also known as uterovaginal agenesis. The type 1 Mayer-Rokitansky-Küster-Hauser syndrome has no extragenital manifestations, while the type 2 or atypical Mayer-Rokitansky-Küster-Hauser syndrome presents with skeletal or renal or audiological abnormalities. This is also known as Mullerian and uterus and renal cervicosomate dysplasia. So we are trying to find out certain genetic, if there is any genetic cause for this Mayer-Rokitansky-Küster-Hauser syndrome. Certain genes like WNT4, WNT9B, which are involved in genitourinary system development, and copy number variations in HNF1B, single nucleotide variations in LHX1 are considered, but their association with the Mayer-Rokitansky-Küster-Hauser syndrome is not so consistent. But we have now found out that GREB1L, GREB1L, is having a strong association with type 2 Mayer-Rokitansky-Küster-Hauser syndrome with renal abnormalities, and this follows a autosomal dominant inheritance with incomplete penetration. This Mayer-Rokitansky-Küster-Hauser syndrome type 2 has two phenotypic presentations. In one case, the side of in our case, the side where the uterus is more aplastic is the same side. The renal is also not present. That is, the renal left kidney is absent and the left Mullerian duct abnormality is noted more here. A common complication in this Mayer-Rokitansky-Küster-Hauser syndrome is endometriosis. Since the uterus is rudimentary, the Sampson's implantation theory says that retrograde menstruation may lead to endometriosis. And this is also associated with this Sampson's implantation theory is also supported by its association with the other Mullerian abnormalities like Herlen-Werner-Wunderlich syndrome. And there are two theories: Mullerian non-fusion mobility, which is since the Mullerian ducts are not fused and not formed properly, there is excessive mobility of this ovary and fallopian tubes. So the Thomson's theory says that this excessive mobility is responsible for the presence of ovary in the inguinal hernia. Whereas the Bowler's theory says that the suspensory ligaments of ovary are elongated in this syndrome, so ovary is able to come into the inguinal hernia. These are two theories which explains the reason for why ovary is in this inguinal hernia. So this slide shows the common associations with type 1 and type 2 Mayer-Rokitansky-Küster-Hauser syndrome. The renal manifestations which usually occur in type 2 Mayer-Rokitansky-Küster-Hauser syndrome, like unilateral agenesis, pelvic kidney, horseshoe kidney, duplex kidney, and skeletal malformations like scoliosis, clipper flail abnormality, hemivertebrae, and cardiac abnormalities can be present in some patients. Hearing impairment may be present in some patients, and other some rare features like inguinal hernia is also present in some patients. Neurological anomalies present in some patients. So these are my references. That's all. Thank you.
Thank you, Adityan, for your presentation. At this point, I would like to first welcome the panelists, panel judges, because I started the program in a hurry. I couldn't formally welcome the panel judges. And I heartily welcome the panel judges, Professor Dr. Raj Murali, uh, Dr. Mrs. Pramila. One second.
Pramila Kolipara.
Pramila Kolipara, and Dr. S.V. Kandasamy and Dr. Ramasamy. All of them have taken their time from their routine work and being here with us to encourage our students. So I welcome the judges and I thank you for accepting and being here for this presentation. And Adityan, I think your presentation was, you have completed your presentation.
Yes, ma'am. And Praveen sir has asked some clarification about the expansion
Yeah,
of
yeah, yeah.
MURCS.
Yes, yes.
It is Mullerian duct aplasia with renal anomalies and cervicosomate dysplasia.
Okay.
Fine,
So
Adi, fine.
Cervicosomate says
ideally,
that cervical abnormalities can be present and the renal anomalies can be present and Mullerian aplasia. So this is a
Okay.
MURCS association.
Okay.
you
Yes,
should
So a
have
simple
put the
question.
expanded form. It would have been easier.
yes, ma'am.
For you also. Yeah. So,
I remembered it, but at this moment
yeah,
I
that's
forgot.
what, because it's always better if you can put the expanded form. And
Yes, ma'am.
one point I just want to highlight is you have mentioned as infertility profile. I think it
Yes,
is
ma'am.
better you say fertility profile. You look
Yes,
for
ma'am.
the fertility, and then if it doesn't, if the patient's the report is not within the reference expected range, then you
Yes, ma'am.
label that particular as an probably contributing to the infertility or whatever you want to come to a conclusion. So you better call
Yes.
it as a fertility profile. You're testing for fertility.
Yes, ma'am.
Yes, and sir, over to you, sir, and over to
Can
the
yeah,
panel judges.
can I just introduce Dr. Pramila Kolipara is a consultant gynecologist here in Britain, and she will be able to throw a lot more light on this particular case, which we've never seen before. The other, and it's strange that this patient, although seemed more to do with gynecology problem, was seen by the general surgeon and treated by the general surgeon to start with. I'm sure Dr. Pramila will be able to tell us more about it.
Yeah. Thank you very much, Adityan. That was a very good presentation. Excellent presentation, in fact. You've
Thank you, ma'am.
referenced it very well. You've got all the facts correct, but this is something that we do see quite commonly, not
Yes,
very
ma'am.
commonly, but quite commonly in the UK. And we relate it a lot to consanguineous marriages. So there are lots of ethnic minorities here where people marry their own first cousins. And we find
Yes,
that
ma'am.
it's much more common in them. So I don't know whether this couple, this particular patient, her parents were related to each other, but
Non-consanguineous marriage, ma'am.
not non-consanguineous. Okay, that's what.
Non-consanguineous.
But more importantly, I don't think we've seen anybody at 28 years. Most of the cases that we see here, if you do not get a period before 16 years, until 16 years, we wait. Girls can get periods at 9, 10, 11, 12. But if they haven't got a period by 16, then they come to see a pediatric gynecologist. And that's
Yes,
when
ma'am.
we investigate and we find this. I cannot believe she was 28 years old and she got married. You said that she had
Yes,
coital
ma'am.
differences. So
She
without
was married for
getting her
1 year.
periods, how did they get her married? I don't know. Anyway, but what
Yes,
I'm
ma'am.
saying is
It's a
these are
mystery
the
for
things
us.
because you get a lot of vaginal agenesis. And you said there that one of the differential diagnoses was an imperforate hymen. If
Yes,
a
ma'am.
woman has an imperforate hymen, which is again much more common than the syndrome that you presented,
Yes, ma'am.
the girls start presenting with severe pain and difficulty passing urine, etc., by the age of whenever they start their periods. Because if you have an imperforate hymen, the blood starts collecting in the vagina. It then pours out through the fallopian tubes into the peritoneal cavity. And they come to us with peritonitis or with severe inability to pass urine. And when we scan, we find that the vagina is full of blood. And all you do is just to make a little incision in the hymen and the imperforate hymen is treated. So it's very rare for imperforate hymens to go, or even a transverse septum to go on till the age of 28, because the patient will have a lot of symptoms. In her case, because she wasn't having a period because there was no uterus, this is what has happened. But at least we know what it is, and what she needs is, like you said, either an IVF or uterine transplants. I think in India they've done a few now. So whether anybody would consider a uterine transplant for her and give her the plastic surgeons will do the artificial vagina so that she can live normal sexual life. But otherwise, her hormones should all stay in good stead. And about the ovaries being lax, you're absolutely right. It's for both the reasons. One is that the ovarian ligaments are not connected to anything, so they are stretched and they're lying free, and that's why they go and herniate like that. But when you look at her hormones that you again presented, the ovaries are working all right. So she does have eggs, and she can fertilize if somebody else carries those eggs. But otherwise, it was a very good presentation. Thank you.
Thank you so much, ma'am.
Dr. Kandasamy, who is a consultant urologist, would you like to comment on the?
Yeah, only thing is, being a urologist for the last 45 years, though I have seen a lot of, renal agenesis on site, I haven't come across this kind of syndrome so far. And of course, this patient presented with hernia. So what I would like to ask is how common this condition to patients presenting with hernia. I'm sure in the general surgery you see a lot of hernias, but even as a general surgeon, I used to see a lot of hernias, never come across any symptoms associated with the uterus. So how common is it?
No.
So ovarian hernias is so rare, like 2 to 3% of all inguinal hernias are having ovary as a content. Ovarian hernia is so rare. And its association with Mayer-Rokitansky-Küster syndrome is so rare.
Just like Dr. Badri asked, in the general surgery department, how did this patient land up in the general surgery department, and you and your professor had a chance to see this patient?
Yes, sir. So the patient did not mainly come to the hospital with complaints of coital difficulties and menstrual abnormalities. She did not even go to gynecologist's problem for so long time. Just for
that's
complaints
very
of
interesting, because I am perplexed by the fact that how did she get married in the first place?
yes,
How
sir.
did she, miss menstruation? I mean, probably they had concealed this fact before marriage or something like that.
Yes, sir. They
Okay.
concealed. I'm not sure about that, but this patient got married 1 year. For 1 year, she is having coital difficulties. Maybe they
Yes.
thought it will be
It
over
will
when
resolve
they
on its
marry.
own probably after marriage.
Yes, sir.
Yes, maybe.
They did not even go to the gynecologist for this complaint. They came to us with complaints of inguinal pain and the swelling on the left side for the past 3 months.
I think Dr. Varadarajan wanted to comment.
Yeah, I mean, I'm very glad I joined this today, because we see a lot of this in childhood in the United Kingdom, actually, because by the time, as Dr. Pramila pointed out, they are about 14, 15, we'll know about it, because you can also get a hemiuterus in Rokitansky syndrome. So you can actually get renal agenesis on one side and hemiuterus. So the uterus on the side of the absent kidney will be absent. So you can have half a uterus. So I've seen that variation as well. And as Dr. Pramila said, they will often come with abdominal pain because they get hydrometrocolpus. So their vagina gets distended and they get pain. And in fact, very interestingly, one girl presented with low backache and was referred to the orthopedic surgeons at the Children's Hospital for low backache. And they, being orthopedic surgeons, we always joke about them. So they just did an MRI without even a full history, because, she's been developing this pain over 6 months, and that's when she started menstruating. So they did an MRI which showed this distended upper part of the vagina. And then they realized she was having this problem and then was referred to me. And some children, even at birth, can present with lower abdominal swelling. And they often have mucus-filled vagina because of this imperforate septum they have in the vagina. So there are various combinations. So, but a lot of them do present in childhood. The one point I was going to make was, if you see a girl with hernias, always you'll have to rule out androgen insensitivity syndrome. So in fact, routinely in the UK now, if we get girls with hernias, we at least do an ultrasound to make sure that they have a uterus and ovaries, because that is the simplest test you can do. Or if they have bilateral hernias and you're going to do a repair laparoscopically, then you can look for the hernia, the uterus and the ovaries when you do the laparoscopy. So yeah, because androgen insensitivity can present like that. But it was a very good presentation and well picked up and well worked through as well. So yeah, so that's good. I mean, of course, the social consequences of not telling people would be different, but that's a different problem and a different situation. Thank you very much. That was a very good case.
Thank you so much, sir.
Can I speak?
Yeah, please do.
I think it's a lot of it has to be in the education that we give to girls. We all learn biology in school, but even I learned about the reproductive system only when I joined medical school. I went to a very good school. We were taught very well. I have no complaints about it, but there was something about not teaching anybody of what a vagina was, what the uterus was. But we as females, I think, need to know about it, because if this girl had gone to school and she was told she needs to get her periods at 11, 12, would she have waited till she was 28 years old to say that she needs some gynecological advice?
This kind of throws the blame onto the parents or educational system or whatever.
And everything. A parent who does not know that, who has a girl child. I mean, yes, we are women, but as girl children, we should get our periods when we are 9, 10, 11, 12, 13. By 14, you should start worrying as to why you're not having a period. Definitely by 16, there are some people who get it a bit later, so that's fine. But by 16, if you do not get, in the United Kingdom anyway, I am a Chennaiite, but I'm just telling you what I practice here. The patient has to be seen by a pediatric gynecologist. So we then look at them and then we do a scan, we check out everything. Similarly, we do, those who have imperforate hymens, like what you had presented there, they've come in and present very often to the emergency departments because they suddenly get pain, and then that's when we notice that there's an imperforate hymen. But every child at birth is checked to see that the vagina is there and it's open. So this is also a neonatal test that's done. Nobody puts fingers in or examines them or anything, but they just look to see whether there is a hymen there and what it looks like. That's not routinely checked later, but definitely there's awareness that you must have a period before the age of 16. And I find that a lot of my Indian patients, they come to me even when their children haven't got periods at 12, 13. So I don't know how they left it till 28. But that's all I can say.
It's more a social problem, isn't it? It's who is to educate the children, who is to what kind of a family background does she come from, Dr. Aditya? Social status?
I think they're in the lower socioeconomic status. So.
Okay.
Did she go to school?
No, ma'am. No, ma'am. They
So
are from
that's so that's a different.
they are from a rural place in I think Kanyakumari. Yeah.
Yeah, can I just come in? I mean, the thing is, I think
sir.
Dr. Pramila's point about neonatal examination is very valid. But however, remember that this girl, if they examined her as a newborn, they would have seen an opening because the lower third of her vagina was present. And nobody will then be, especially in a neonate, look for anything more than that because, all neonatal screening is to make sure their girls have got 3 openings. And so when they see 3 openings, they will assume that it is okay. So, yeah. So sometimes it's a bit like, in pediatrics, there's another condition called rectal atresia. So where the anus is present, but the rectum is absent. So actually, when you first see it, it looks like they've got an anal opening, so everything should be all right. Yeah. And in fact, worldwide, for some reason, the highest incidence of rectal atresia is around Madurai.
Okay. Okay, interesting. Raj Murali, would you like to comment on the presentation?
Badri, I really don't have any comments because I know nothing about this condition. And in fact, until last night, when I decided to look this up, I had not even heard about this. But I really enjoyed the presentation. And also, I want to thank Dr. Pramila and Varadarajan for excellent discussion. So I learned a lot and I enjoyed the presentation, but I have no other comments. Thank you for your participation.
Thank you, sir.
I think the other panel member, is he here?
Yeah, Ramaswamy.
Raj, yeah.
Yeah. Hi, Aditya. That was an excellent presentation. I enjoyed it and learned a lot. Never heard of this before. And your presentation was excellent with beautiful slides and also laparoscopic pictures. It was nice. Question for you. You had a
Yes,
long name for the syndrome, Rokitansky, Mueller,
yes, sir.
etc. Did you look into any of those names, get any historical information? Because I'm a history buff. I like historical information.
Yes, Mayer-Rokitansky-Küster-Hauser syndrome. So, I read about this in an article, but I forgot most of the facts because I read it long back. The history part, I neglected it. It was successively reported by certain people. Like back in the 1600s, in that time. So first Mayer, then Rokitansky, then Custer and Hauser together, they reported few cases. So finally, when they named the case,
Where was it? Was it in Germany?
uh, I'm not sure, sir. I think in Germany.
I was interested in Rokitansky's name because in general surgery, there's a condition called Rokitansky-Aschoff sinuses in people with chronic cholecystitis.
Yes, sir.
So I looked up Rokitansky. It's interesting. He was a 19th century pathologist. Apparently, he has performed more than 60,000 autopsies. And his very first autopsy was on Ludwig van Beethoven,
Wow.
the classical composer. And he was curious why Beethoven was deaf, and he wanted to look into it, but he never found it. And his wife also has a very high musical career, opera singers, sang with all the famous composers. And Rokitansky's name is associated with a lot of medical conditions. One of these, and Rokitansky nodules, something to do with another gynecologic condition. So it's a very interesting person. He was also politically active. So thank you for your presentation. Enjoyed it.
Thank you, sir.